The following is a brief segment from our hour-long PL Voices Clinical Recommendations webinar held on May 12, 2016, and discusses how and when non-statins should be used to treat dyslipidemia. This one is led by session moderator and PL editor, Dr. Sherry Boehringer. You'll hear the voice of editorial board member, Dr. Barbara Yan. You'll also listen to an expert in lipid management and lead guideline author, Dr. Donald Lloyd-Jones.
I do want to talk about the situations where it might make sense to start a non-statin. And within our article, we actually have two where it possibly could be considered a non-statin could be added to a statin. And those two situations that we have are patients at very high cardiovascular risk that can't tolerate a high-intensity statin, or those that don't get the expected LDL lowering from their statins. So are there any other situations, Don, that you would suggest that we consider when we talk about adding a non-statin to a statin?
Sure. I think the two other clinical situations where you would expect to need one would be patients with quite severe hypertriglyceridemia, but also patients with the familial hypercholesterolemia phenotype, where typically if they're starting with an LDL cholesterol in the 250, 300 or higher range, there's just no way a statin is going to adequately lower their LDL cholesterol. But I think it's important to define what is the expected LDL lowering from a statin. And so just to remind people quickly, if it's a moderate intensity statin, they should be seeing a 30 to 49% reduction in the LDL cholesterol from baseline. And if it's a high intensity statin, they should ideally be seeing 50% or more reduction in the LDL cholesterol.
So the first kind of scenario that I'd like to discuss is that patient that's just at a very high cardiovascular risk. Let's say, for example, they can't tolerate atorvastatin 80 a day. They can only go up to atorvastatin 20. So you've made that decision that you'd like to use a non-statin to further hopefully reduce cardiovascular risk. And yet there's only one non-statin that seems to improve cardiovascular outcomes when added to a statin, and that's ezetimibe. So we actually recommend that, leaning towards ezetimibe if a non-statin is needed. So do you agree with that recommendation?
I do agree. Based on available evidence, as you said, until very recently, we did not have any trials that had demonstrated additional benefit in terms of efficacy for adding a non-statin, and this was particularly true of niacin. No extra benefit, significant extra harm, until the Improve It trial was published, and there was a statistically significant but quite modest 2% absolute risk reduction over 7 years of therapy when ezetimibe was added to a moderate, and I would emphasize that, statin in patients who were admitted for an acute coronary syndrome event. That 2% absolute reduction converts into a number needed to treat of 50 patients for the additional therapy over and above the moderate intensity statin.
I did also want to definitely bring up the PCSK9 inhibitors such as Praluent, mainly because they don't have cardiovascular outcome data at this point, and they're very expensive. And so we are telling primary providers not to be too tempted to try these PCSK9 inhibitors. So Don, would you agree that you wouldn't go straight to them?
I would agree completely. I think they are at present, because we don't have long-term safety data, in addition to the fact that, as you pointed out, we don't have real efficacy data. I don't think we're ready to go there for anything other than the very highest risk patients who either are not tolerating statin or are not tolerating enough statin to get the effective lowering that we're looking for. Or, again, patients with familial hypercholesterolemia phenotype, where they need substantial amounts of LDL lowering in order to reduce their risk.
There might be a situation where it might make sense to add a non-statin to a statin with people with high triglycerides over 500 to possibly reduce the risk of pancreatitis. So do you have any preference between a fibrate or omega-3 fatty acids being added to a statin? Which of those two?
Sure. In general, I do try to reach for the fibrate first, typically fenofibrate, usually quite well tolerated, easy to take, single pill dosing, per day. The pharmaceutical grade omega-3 fatty acids at doses of 4 grams per day for pretty large pills and significant expense as well. And therefore, I'll try to reach for the fibrate first, remembering that even fenofibrate may have some drug interactions with certain statins.
if an agent is going to be used for monotherapy, meaning for whatever reason a patient can't take a statin, they just can't tolerate it, period. You've tried many times and they can't tolerate it, which agent should you use? And we do say to lean towards the bile acid sequestrants. So what are your thoughts on that?
You're correct, and the guidelines certainly came down on the side of if you really can't use a statin, then use something that, when used as monotherapy in prior trials, at least showed some benefit with an acceptable safety profile. Therefore, cholestyramine should and would be, I think, first-line choice among the bile acid sequestrants.
Thank you. And I do want to get to one more question. When it makes sense to stop a non-statin. So let's say, for example, somebody has been on a combo of atorvastatin plus a fibrate for many, many years, but they seem to be tolerating it well. And now we know there's no data to support this combo. Does it make sense to stop? So how about you, Barbara, from a community provider's perspective? Do you think you'll be taking more patients off niacin and fibrates in your practice?
I think if they haven't already taken themselves off, then yes, we should have that discussion and explain why we don't believe this would be a continued benefit to them.
Okay, well, very good. And I think that's an important point, that I think a lot of people were started on fibrates and niacin many years ago. And now that we've learned that they're not beneficial when used in combination with a statin, it makes sense to go ahead and discontinue those.